I'm Dr. Jennifer Yarden, the CEO and co-founder at Curewize. At Curewize, we aim to accelerate the personalized treatment of cancers common to children, adolescents, and young adults. Our lead product is ProAll for the prognosis and monitoring of acute lymphoblastic leukemia patients. Acute lymphoblastic leukemia occurs in around 48,000 patients a year, with a median age of 13. It's caused by an overproduction of immature white blood cells in the bone marrow, so the other healthy blood cells aren't produced. Thus you have less red blood cells, less platelets, and less healthy white blood cells to fight off infection. And the patient succumbs to many symptoms, such as infection, tenderness in bones, fatigue, and easy bleeding and bruising. Currently, physicians use minimal residual disease tests, also known as MRD, to plan how to treat their patients. Here they take a small aspiration from the bone marrow and count the number of leukemic cells left in the bone marrow after starting treatment, and decide whether to give the patient a standard therapy or a more intense therapy. This is an example of a risk-based treatment protocol, which can last around 2 to 3 years. Notice the different stages: pre-phase, induction, induction consolidation, reinduction, and maintenance. Also notice over here on the top you have the risk stratification: standard, intermediate, and high. At the reinduction phase in this particular protocol, patients are given a different level of treatment, very intense for the high-risk patients and a lot less intense for standard patients. This is done in order to ensure the high-risk patients survive. If they're not treated with this intense treatment, they may relapse and will only have around 20 to 40% chance of survival. While we don't want patients who only need a low level of treatment to succumb to long-term side effects. As you can see here, these side effects include secondary cancers, lung damage, liver damage, psychological problems, and shorter lifespan. At Schneider's Children's Medical Center in Israel is a central lab that performs MRD analysis for all of Israel. They realized that a better predictive test is needed in order to more accurately assign AL patients treatment. They came to this conclusion because of several factors. First of all, MRD results are only available after starting treatment. MRD is highly patient-specific and therefore laborious and costly, and can take up to 16 days to perform. Also, MRD molecules may change during the course of disease, which makes the monitoring test less reliable. Schneider's Children's Medical Center chose to search for a better biomarker in microRNA, which act like small switches that turn off the production of certain proteins. These microRNA were found to play an important role in the suppression and progression of cancer. So Schneider's Children's Medical Center then proceeded to create the ProAll prototype by performing 3 different studies. The first study was a discovery study where they screened 48 bone marrow samples taken at diagnosis from AL patients by 979 different microRNAs. They chose the 2 microRNAs whose low levels associated with the most adverse prognostic factors. Then they proceeded to the design study. And here they show that ProAll microRNA can predict which patients will have a more risk to relapse and which patients will have a lower risk to relapse, and thus need either more intense treatment or standard treatment. And then again they validated these results in another study where they show again that ProAll can predict relapse and can help assign patients treatment. Curewize will now proceed to do another retrospective study in order to receive regulatory approval and widespread acceptance. Now let's take a look at the advantage of ProAll microRNA assays over MRD assays. MRD assays measure the proportion of residual leukemic cells. Results are available 2 to 11 weeks after starting treatment, is patient-specific, laborious, involving many stages, and is costly. While the ProAll microRNA assay measures a proven tumor suppressor, results are available at diagnosis, the test is universal, is relatively simple, and cost-effective. And when we look at the technical implementation, we find that reliable and reproducible techniques for assessing MRD are still lacking, while the PRO technology is straightforward, reliable, and reproducible. Now, importantly, we must compare the performance. Around 30% of patients who are defined as non-high risk by MRD do relapse in the end. PRO is able to detect these patients and define them as high risk. Both PRO and MRD are independent predictors and can work together in order to find patients who need a more intense treatment. Interestingly, PRO positive patients are at twice a higher risk to relapse than MRD positive patients. With a global addressable market of $250 million, I am inviting you to partner with Curewize to help physicians make more accurate treatment decisions. Not only will you benefit from your investment, but also all other stakeholders. Physicians and hospitals will be able to treat their patients more accurately. Insurers will pay for more cost-effective prognostic tests. Laboratories would welcome less laborious tests. And most importantly, young patients have a higher chance of becoming healthy adults. Thank you for your attention.